Welcome to the Lipoedema podcast, hosted by Shell and Tiana. Our aim is to make noise around lipedema and educate as many people as we can about this disease.
Our guest list contains professionals who work in the field and women who live with lipedema. Thank you for joining us.
Dr. Lekich has worked in operating theatres for over 20 years, initially pursuing a career in eye microsurgery. Inspired by his then wife, who developed a clot in her leg during pregnancy, he then completed formal venous and lymphatic disease training. In his venous practice, Dr. Lekich has conservatively managed lipedema for over 10 years. He shifted to the surgical management of the disease once he established the purpose-built licensed Miami private hospital and training in Germany with Dr. Heck. Dr. Lekich has collaborated with world's leading lipedema surgeon, Dr. Heck, of Germany's LipoClinic. Dr. Lekich has made several visits to Germany for personalised training with Dr. Heck, who has become his mentor and good friend. Dr. Heck has also personally spent a number of days visiting Miami Private Hospital in 2017, hosted by Dr. Lekich. This technique of lipo-extraction surgery has been perfected over 14 years, now making it available in Australia.
Apart from Dr. Lekich's extensive training in microsurgery, minimally invasive management of venous disease and lipedema surgery, he has a formal law degree, has been admitted to the bar and has completed a Masters of Business Administration. Dr. Lekich is passionate about education and has established a conference and skills training centre.
Further, his facility is accredited by the Australasian College of Phlebology, ACP, as a training centre. He is a fellow and active board member and past vice president of the ACP. Welcome back to the Lipoedema podcast. We are your hosts, Shell
and Tiana, and today we are joined by Dr. Chris Lekich. Dr. Lekich, thank you so much for joining us today.
Thank you, Tiana, and thank you, Shelley, for having me here.
Are you most welcome?
Oh, such a pleasure.
I'm going to start off and get straight into it. How did you come to learn of lipedema, and what about it made you so passionate about supporting the women affected by lipedema?
So my background as a phlebologist started 18 years ago. At one stage, I was actually pursuing an eye career and working at the operating microscope, and I changed career paths because at that stage, one of my loved ones had a blood clot in varicose veins, and my personal journey changed course to become a phlebologist and do a fellowship with the Australasian College of Phlebology. The other thing that happened personally, I needed a vasectomy, and then I could actually see as my patients who were impacted with swollen legs were affected with veins, lymphatics, and lipedema. And I was actually quite mesmerized that in a thick textbook, which was our Bible, the vein book, there was really only one paragraph of lipedema. If I was writing the textbooks now, it would be a whole 10 out of 11 chapters on why women have swollen legs. And so at that stage, because I'd had an eye for a facility that would enable us to manage all manner of leg conditions, and I felt that we could add something to the landscape in Australia, which was completely missing. No one was talking about lipedema. Vascular surgeons 18 years ago, or phlebologists, or even plastic surgeons. And I was very fortunate that about 8 years ago, I was introduced by one of my patients who I managed her veins. By that stage, we'd already had the blueprint and were just about to finish the hospital, and she's connected me with Dr. Heck, and that was history. 4 trips to Germany with training, and then he came to Australia to supervise my first surgeries in the theatre that I work now. So I guess the passion comes from an ability to, and the privilege to be able to look after women where, as you know very well, ladies, and your audience, there's very much a neglect in this space.
Absolutely. And we try and fill those gaps. So until you'd seen that in the textbook, had you heard of lipedema before?
No, I guess it was even in my first year of basic training, I read it and thought, I've never heard any of my mentors talk about this. Even currently, when I'm having visiting surgeons, vascular surgeons, they spend a day with me in the clinic and then go, where has this disease been? It's been obviously under my nose. I've never seen it. And these are some very seasoned specialists. So they learn very quickly that conservative management makes a huge difference. And obviously surgery that they've never ever witnessed before, they can see the benefits that patients have with surgery.
A lot of our guests that we've had on who are lipedema warriors have said that when they've gone to doctors and said, oh, I think I have lipedema, they're like, oh, you mean lymphedema? So it's just that, that confusion and not enough exposure of this condition yet. Yes, but we're getting there.
Just on point, Shelley, at the inaugural World Congress 2 weeks ago, which seems like a lifetime already ago, it was very clear during the Delphi communications that as a standard, as practitioners, we should actually adopt the word lipedema, not lipedema, because lipedema sounds too much like lymphedema. And rather than go change the name of lipedema, we should pronounce it in a way that is all very different to lymphedema and lipedema. So lipedema is the way to pronounce it.
There you go, because we've been trained the other way. We've been schooled to say lipedema because that has a greater deviation from liposuction and lymphedema. But okay, so we're going back to lipedema.
Oh, there's a solution for distinguishing it from liposuction as well. If you want, we can talk about it later.
Okay, absolutely. So that's a great segue, because I want to talk now about what method of lipedema extraction surgery and what made you choose that style.
Yeah, so clearly I'm not cosmetic, I'm not plastics, and but where I got my training was from a world guru who his team, and for 20 years he's been doing lipedema surgery and somewhere around 3,500 cases a year. So it was quite clear when I went to Germany and being very connected with the concept of being able to offer this surgery in Australia in our hospital, I wanted to explore techniques. So I had seen some people do liposuction. It looked very casual. It looked, I guess, in a way where you sort of melt down the fat and then you suck it out. But what I saw in Germany was completely different. It was a protocol to actually remove the fat. And very much in Dr. Heck's stable, we were all trained that the surgery is to remove the fat so it doesn't come back. So it's actually a very physical process and is very much directed with water extraction techniques. So for me, what I could see very clearly with the protocol, the aim was to remove the fat so it doesn't return. And we touched on this in Germany as well, that, you know, just calling it simple liposuction gives the impression perhaps to anyone who casually comes across patients with lipedema and don't know it, that it's just same old techniques that are used for patients who might have obesity. So the concepts revolve now in terms of the general thinking. It should be either referred to as lipedema reduction surgery or extraction surgery. And it's interesting, being in Germany, one thing I could see across the board as we were being exposed to different techniques, even amongst those who had a special interest in lipedema, lipedema is that there's no real standardized surgery in the world. So that's the next challenge, is to get to the point to say, well, what is potentially the best standard, the safest, the best recovery times, and what is the endpoint effectively when we're going in and doing surgery, and managing women with swollen legs, the lead up to surgery for comorbidities, and then obviously the aftercare.
Oh, great. You mentioned that it should be renamed to lipedema removal, or lipedema extraction or reduction surgery. And I completely agree. I feel like there is a stigma with liposuction that it is cosmetic, like solely cosmetic. And so when I do talk to people about how I'm treating my lipedema, I never mention liposuction. I always say lipedema extraction surgery, and I think I use that to protect myself from that stigma. But you're using like when people ask me what does the surgery entail, I sort of have to mention liposuction, like it's using a similar approach, I suppose, getting fat out. Talk to us about some of the other methods of lipedema extraction surgery, because you use water assisted, as you said. What are the other ones that you found other surgeons?
Sure. So just as a brief note prior to answering that, I think it's very important that we do talk about lipedema surgery, because that forces, I guess, the community at large, medical community, to start questioning what is lipedema in the very beginning, and then to understand the patients are very different, the fat is very different, it's very fibrosed, and the techniques to remove it are very different as well. And the other thing to also make a point, and very important for regulators and decision makers to understand, be it APRA, be it Medical Defence Organisation, be it health funds for the hospitals, that just because you've got a cannula in your hand doesn't mean you're going to use it the same way. So, a hammer in one hand will be very different from a hammer in someone else's hand. I'd like to think we're not doing crude hammer-related activities, but the cannula and the way that cannula is used is very, very specific, certainly when I'm approaching lipedema. So the different techniques that generally were and effectively spawn out of Germany 20 years ago were techniques that essentially had an element of local anesthetic in the leg. They might be tumescent type techniques where they fill the leg up with lots of fluid, in fact, really, really fill it up quite tense. And then they come back maybe an hour later to try and remove what is more like a dissolved fat. Then there'll be the techniques where power-assisted techniques are used, where doctors rely on a very mechanical motion of the cannula to remove fat. And then there's the water-assisted technique, where very much there is a water jet to infiltrate the tissues and to remove the tissue using water jet, but with a very active leading edge on the cannula. So that technique is very particular in that there are no casual movements. You need to be very even and fully remove all that fat and obviously protect all of the tissue. And if patients don't have much tissue and they have a tiny little bit of fat, then you need where you've got virtually zero margin of error. You have to be very accurate in how you remove it from the hips all the way down to the ankles, and from the wrists all the way to the armpits. And obviously there'll be various approaches in terms of removing a little bit of fat all over the body, or removing it completely in one area. Other techniques that have been talked about, particularly at the World Congress, is, well, what part does the high energy ultrasound modalities, which you might find in VASA or Ultra Z, how are they effective? in terms of removing all that fat. And then we got exposed to techniques where they use more traditional micro-air techniques. In Germany, there's a facility to sort of break down the fat, but then they make larger incisions and pretty much squeeze fat out. So it kind of erupts out of the access port. So a lot of patients talk about seeing that video and wondering, you know, why don't you do that technique? And I'd rather not elaborate in this forum, but if you remove all of that fat, and particularly with the technique that I've been trained to do by Dr. Heck, I tend to find that I don't need to rely on those other modalities. Of course, a lot of conversations come about in terms of the unwanted disproportionate skin that might be still there after women have had that disproportionate lipedema fat removed. So I guess in that space, people are thinking, what can you do with skin shrinkage modalities? So that would be adjunctive to when we're doing surgeries at the same time. And certainly there'll be doctors that have put their minds to it. We've recognized that's a challenge for women, and obviously how to address that skin is something that we're dealing with at the moment, with redundancy in skin to try and normalize the patient's final outcome. So lots of toys and lots of different ways to play with it, but obviously there's a lot of great experience out of Germany that has led the way for 20 years.
Very cool. And I think that variety of techniques lends itself to the fact that you're all individuals with, and you need to work for what's best for you, your physicality, your comfortability, and your patient. So it's nice to know that there is a variety of methods as well. You touched on it just briefly, but you talked about not having a cosmetic focus to your procedures. And I just wanted you to expand a little bit more. I understand in my own brain, having a medical focus from my point of view felt like the most important thing. I wanted all of the diseased tissue out so that it was not likely to grow back. But in being a woman and being wanting that body positivity, cosmetic outcome was also a factor that I found to be important. Can you talk to us about what you mean by having a medical and not a cosmetic focus?
Sure. Good question, Tiana. And I guess if you've got a medical focus for the disease and you've got a true endpoint which you feel is something you can achieve, more often than not, the rest of those things work themselves out. So, for instance, in the lower leg surgery, to be able to do surgery, remove fat, so patients for the first time, which for many years haven't seen the knees, the shins and their calves all the way down and their ankles. That's not my focus, but I know that's a big plus. And even though you might consider it cosmetic, for me, it's the only way we're going to achieve that is by removing all of that fat and doing it aggressively without sounding like we're heavy-handed. So it's absolutely correct that if you're looking for normal form and body function, a disease process that's completely robbed you of that and is actually progressing, you need to tackle that head on. And very acceptable that women that don't have that problem take it for granted that they can see those body structures. So the nice thing in the lower legs from the knees down, or the lower part of the kneecap down, is almost every patient will achieve that without having to have any skin work done, because the diameters aren't so big. But where they've been challenged in the thigh or in large areas in the upper arms, then obviously we can add extra adjuncts to that to try and achieve that result. And obviously patients who have considerable amount of excess skin, we've removed 40-50 litres of fat, then, you know, we work very closely with plastic surgeons who will try to restore that normal function. And in fact, they are working to create a normal body functioning. And if you talk to them as well, their headspace is normal appearance, whereas patients will be thinking about their cosmetic appearance. But defining what's cosmetic and what's normal surgical function, I think if you've got a disease process that's robbed you of that, directing the surgeries to that, it makes it a big step ahead.
Yeah, thank you for that explanation. It's good for our listeners to get ahead. It's not that you don't care about their cosmetic outcome, but your focus is to get rid of the disease, and that makes a lot of sense. And you work in partnership with cosmetic surgeons.
So the plastic cosmetic surgeons, for skin excision, if they need that, they will get a referral to a very good one. If they don't, and we can avoid that, then we can explain how we can do that. And what actually makes it interesting for me, and I enjoy very much, is when I see the patients coming to the end of their journey as they're having stage surgery, and they put their little finger on one little spot. And they go, well, I wonder if that's a little bit of lipedema. My therapist has noticed a little lump there. And I say, well, that's great. I'm glad that we're taking away the Ayers rock of tissue and you can focus on a little pebble. And I always welcome that. But I also remind the patients that if lipedema is going to become an ongoing problem, you'll see it grow, you'll feel it grow. Those little pebbles, we can check and we can manage those as we're doing further surgeries and tweak them if we need to.
Very good. And that's how, with the continuation of conservative management, those are powerful tools as well. Okay, you touched on it again, staged surgery. So talk to us about how you approach staging with your patients.
Yeah, and look, really good question in this context. In Australia, we've seen a cosmetic surgery spotlight and concerns about mega liposuction, where patients have 15 litres of fat removed and then they're sent home on the same day. And then obviously regulators coming in with guidelines to protect that. So even in Germany, they're doing mega liposuction, but even those facilities, if you get the impression that they're going to take all that fat away in one hit, that's not correct. If you've got an eye to removing fat and that full thickness of fat in one area of the body, you have to have important regard to safety considerations. And the ones that come and in that order of level of surgery in terms of consideration, we don't even have an eye for how much fat we're going to remove. It's going to be over what surface area, how much local anesthetic we can use that's not going to cause an overdose for the brain or for the heart, and then to essentially ensure that patients will not bleed out and will recover and will be able to get up and not need to be in hospitals for a long time, but to be complete in that surgery. So that staged approach, most places, even in Turkey and Spain and Germany and Brazil or wherever, or Thailand, wherever patients have a concept that they're going to get maybe more value for money, one needs to be very clear. Are you actually having a dedicated approach to remove that fat, and with the aim so it doesn't come back? So in my practice over 7 years, it's really not changed any significantly, in the sense that if there's this 5 litre rule we think is safety, and certainly I'm having a lot of conversations with medical defence organisations to tell them you're actually going to push patients overseas if you give them the notion that more value for money is done overseas. But it really hasn't changed my practice in lipedema, in the sense that I really want to even out those surgeries to make sure that they have a safe journey and all the fat's out. So for me, it's if you come with early lipedema, very early, you are going to need 2 surgeries. No one can get all over the whole area, really, without those young patients usually who are very thin, and the margin of error for that body weight is very thin. It's a percentage body weight, which is important, but moreover important is the amount of anesthetic fluid we use. And if you're a featherweight, we walk a real tightrope in terms of the amount of solution we can use. So that's why we stage the surgery. 90% of patients will be either 2 surgeries, and if they're more progressed in the thighs, it'll be a 3rd surgery. And then there's the outlying patients who might need 4th or 5th surgery. And we're always looking to minimize the amount of surgeries, but to maximize the safety and to make sure we're doing our best so it doesn't all grow back.
Yeah, so it really is just an individual thing, isn't it? Like, we are all so different. So it really, yeah. As we've been saying with a lot of people, we have a common thread of lipedema, but we all present so differently. So the surgical staging and the approach is going to be different for all of us as well.
Absolutely. And if I wanted an easy life, I wouldn't be doing lipedema surgery. I'd stick to my microsurgery and just the veins. But the reality is, you're right on, Shelley. It's age differences, it's comorbidities, it's how firm the tissue is, how much EDS they've got, POTS, autoimmune conditions, blood clotting conditions. So very much we have a mind for that as we put all this together, to try and ensure that our patients have safe surgery as they proceed for their journey.
Yeah, excellent. Thank you so much. Now, you mentioned that you went to Germany for the inaugural World Congress. How exciting. Can you talk to us about any new knowledge or research that you found particularly fascinating that came out of that Congress?
Yeah, I think the 2 take-home points for me was probably more on the global world scale, with experts coming from all over the globe. They were varied. They were from plastic surgeons, phlebologists, vascular surgeons, trauma medicine, orthopedic surgeons, gynecologists. There was like a huge mix of people who have a special interest in lipedema and surgery and have dedicated their lives to it. And then obviously the physicians, like the Karen Herbs, the endocrinologists. And I think what we're going to see more and more of is a huge diversity of doctors who bring their expertise in that headspace. But without a doubt, apart from that diversity, is also the fact that it's a global world problem. It's the lack of awareness in countries, in first world countries like Australia, the UK, in the US, is quite remarkable. And then every jurisdiction is trying to grapple with what they consider obesity or fat, lazy women, and cosmetic surgeries. The UK have shut down surgeries at this point, routine surgeries, as the government explores the NICE guidelines. Recommended that surgery not be done because they had a death from a fat embolus syndrome in the brain in 2019, an American lady on her 4th or 5th surgery. So, which is very tragic, but that jurisdiction has tried to grapple in their own little world what this looks like. So there's no overlay of international experience to say, well, this is where the standards should be for diagnosis, for conservative management. And the second take home that I took from Germany was just how diverse the surgical approaches were based on the backgrounds of those particular doctors. And it was a little bit of time for a bit of fun. It was one of the most intense conferences I went to, in that we started at sometimes 7:30 in the morning and went through to about 7 p.m. And every 15 minutes or 12 minutes, there was a new speaker. There was some basic science and research. And then there was a lot of good work done in terms of how to have a world consensus statement. So I encourage all of your listeners to go to the World Lipedema site, and join up as members. They've just launched that during the Congress, and Lipedema World Lipedema Initiative, and become members, and both sufferers and those patients and those doctors and therapists and those interested in making the lives of lipedema patients better, to get behind that initiative. It's fantastic.
Oh, we will definitely put that link in our show notes. That's amazing. And I just imagine, like, you're so passionate about lipedema, and then to be surrounded by all of these information and all of these people sharing your passion, but coming from all these different angles. It would have been just like mind-blowing to have you all in one place. It would have been amazing.
Oh, it was a blast. It really was.
Yeah.
It was fantastic.
Now, you did mention there about obesity, and like there is a lot of fat stigma and weight stigma around women, which like a lot of our listeners have said, even after they got their lipedema extracted, they were like, are you sure it was lipedema and it wasn't just normal lifestyle fat? Is there a way to know how much is lipedema and how much is lifestyle? Is there such a test?
Sure. There's not really one test. I think for young women coming through today, the advantage they have of getting information early is early, appropriate conservative management. And then if they're moving to surgery because they do not want to end up like their sisters, mothers, grandmothers, then appropriate surgery. For patients who have had this disease for longer and have lost more of the mobility, perhaps have had more of an inflammatory diet that's caused this vicious cycle between lipedema and lipedema and lymphedema, and then you throw on top of that the venous system, that's an ugly, horrible triad of activity, then those women will have further swelling, not just in their limbs, their arms and the legs, but then they'll start growing further and further in their abdomen. And we have a young lady at the moment in Australia. She's been very vocal about her disease, and she's now in a motorized wheelchair. She's had 3 liposuctions with a specialist. And on her 40th birthday, she was in intensive care. She's going to die from this condition because she's drowning from the inside. So, you know, when patients like that are seen, they're told, you've got obesity, but she's got a total body swelling now because this inflammatory tissue has put so much burden on a lymphatic. So how do we tell? If patients have got some secondary obesity, they will be able to lose a bit of that. And they don't have to get flat board stomachs to lose that. But as they engage in an appropriate conservative program, they themselves get to a point where their legs feel softer and their symptoms significantly abate. So for them, you either keep living like that, you'll never get rid of the lipedema, or you have surgery. In my practice, when I'm doing the surgery, I can feel what is quite inflamed tissue, short of getting in with the microscope and checking every cell. We can feel the even removal of that tissue through tiny little ports. And then if they've got some secondary obesity, they tend to lose more weight as they're getting more and more active in the process of shedding that inflammatory tissue. So lifestyle is really important. It will only address essentially, it will address secondary obesity, but it'll reduce inflammation. And I've seen a lot of patients that had gone through the surgery and then they have life speed bumps along the way. And I had one patient who was in intensive care for 6 weeks after she'd had a leg surgery. I was asked to make comment about how her legs were going, because for 6 weeks while she was in a coma, she was having 100% proof carbohydrate nasogastric feeding. Her legs were super, super soft. Where patients put on weight if they haven't adhered, as you said earlier, Tiana, to keeping those lifestyle decisions like anti-inflammatory diets. If they put on weight as a consequence, they don't put on the lipedema tissue. They put on some weight all over their bodies, and sometimes their legs look like quite disproportionate compared to the rest of the bodies, but they have the ability to lose that secondary obesity. So has that answered your question?
Absolutely. Thank you. We are running out of time quickly, but I wanted to ask before we say goodbye, what is next for Lipoedema Surgical Solutions? What is your next goal?
I guess the next goal is to really work hard, particularly in a post-COVID environment where we have such a strain on our medical system. You know, we've got major hospitals cancelling theatres, cancelling specialists, looking at, you know, the pressures of revenue. I guess we have to compete against all of the increasing costs, not just in consumables, but also wages and all of the increasing requirements for licensing and regulations. So that's on one hand, and as the CEO of a hospital, wanting to make sure we've got the safest environment for the patients, we still have to make sure that all of those tick boxes are there. On the other hand, I'd love to do this surgery for everyone. And then there's everything in between. So the goals for me in the future is to have like-minded doctors who have a special skill set and to be able to continue the formal training that we do at our facility. We've made it very public to the health department, to medical defense organizations, to Medicare, to the health funds. This is what we're doing with supervised formal training and to ultimately make the surgery more accessible and ultimately start leveraging on all of the infrastructure we have to try and make it more affordable for patients.
We'd like to thank Dr. Lekich for his time on the Lipoedema podcast.
If you would like to get in touch with the Lipoedema Surgical Solutions, the links are in our show notes.
Thank you for listening to the Lipoedema podcast. Lipoedema and its symptoms vary from individual to individual. The opinions and advice voiced on this podcast are of a personal nature and used for educational purposes.
Please take away from this podcast what resonates with you, and please see your GP or preferred specialist for diagnosis and healthcare. We are Shelley and Tiana from the Lipoedema podcast. Until our next episode, bye for now.